A very good evening, everyone. Thank you for joining us for the topic of Association of Metabolic Syndrome and LUTS, as one of the webinars we have as a part of a pro-metallurgy webinar series. So today we have with us Dr. Sanjay Sinha.
Hi.
Hello, sir. So as we are all aware, sir is an ordinary professor in Apollo Hospital's Educational and Research Foundation. Along with that, he is the senior consultant urologist and transplant surgeon in Apollo Hospital. So this eminent speaker of ours is an editor of several journals. Along with that, he has had numerous paper presentations and publications. He is also the recipient of several awards and fellowships. With a warm welcome, sir, we would ask you to please share your pearls of wisdom today for this topic. Thank you so much, sir, for sparing your time. I'll stop sharing my screen, sir, so that you can go ahead with yours.
Can you see my slide?
Yes, sir.
And can you hear me clearly?
Absolutely, sir.
Perfect. Thank you so much, Dr. Shamashri and Sipla, for inviting me for this presentation. And it almost foxed me when I received this mail and message that I had to speak on pro-metallurgy. And I actually did a little bit of homework, searched what this was. And when I went on Google and checked, I didn't find this word anywhere. So it now has become clear to me that this is a term that has been coined by Sipla, and I must appreciate their intelligence or smartness in coining a term like this, because I think it really, in a single word, captures what we are going to discuss today, and that is the link that we are going to share with each other between the prostate and metabolic disorders. This is a subject which has become more apparent to us over the last few years. This is not something that we read about when we were training or even in the initial years of my practice. But we do know now that metabolic syndrome has a profound impact on all aspects of lower tract symptoms, both in men as well as in women. And for the urologist, identifying the metabolic syndrome component is critical. And for the physician, identifying the lower tract symptom component is critical, so that we can deliver the best to our patient and we have a satisfied patient at the end of the day. I have no disclosures for this talk. So what's the plan for this session? Over the next few minutes, we'll discuss very briefly what is metabolic syndrome, which I'm sure you all know better than I do. What are lower tract symptoms? What is the epidemiological evidence of an association between these two conditions? What is the impact of metabolic syndrome on lower tract symptoms? What is the impact of management of metabolic syndrome on lower tract symptoms? The approach to the management of lower tract symptoms. And here I will digress a little and perhaps cover a little bit about the general management of lower tract symptoms, along with some references to metabolic syndrome, because I think that's important for all of you. And finally, a brief summary of what we've discussed. And I would appreciate questions at any point of time. If you have any questions, comments, anything you'd like to communicate, do share them through whatever the platform that you are on. And Dr. Shamashri will get it to me, and I hope to be able to discuss or answer or bring forth your comments for the rest of the audience as well. So metabolic syndrome was first defined by the WHO in 1998, and it was defined as a set of conditions, a group of risk factors associated with heart disease, stroke, and diabetes. And there are various definitions which all incorporated combinations of a large waistline, high triglycerides, abnormality of blood pressure, and high fasting glucose. And it became clear that the number of risk factors that were there was proportionate to the overall risk that this condition conferred. It also became clear over a period of time that this was fairly common, and about 1 in 3 Indians and 1 in 3 individuals in the US suffer from metabolic syndrome. And the highest increase in metabolic syndrome that we are now seeing is actually occurring in the lowest socioeconomic countries and in countries like India. The prevalence increases with age, and women have a higher risk. So all these different definitions of the metabolic syndrome were harmonized into a single set of criteria. And this was published in a very widely quoted, cited article by Alberti in Circulation in 2009. And you can see the 5 different criteria here. I'll not go into the details, except to say that the waist circumference obviously has to be country or region specific. And you need to have any 3 of these conditions to give the label of metabolic syndrome. So then what are lower urinary tract symptoms? Now, when I was doing my graduation, we used to have this term prostatism bandied about all the time. And it was only in 1994 that Professor Paul Abrams from Bristol in UK coined the phrase lower urinary tract symptoms, or LUTS. And you'll see in a moment why that was so important. LUTS refers to symptoms which are related clearly to the lower urinary tract. It's the overarching term to describe symptoms related to storage, voiding, or post-micturition symptoms that anybody might suffer from. Now, symptoms which are of the lower tract are not necessarily due to the prostate, and hence using the term prostatism can be misleading. Not all obstructive symptoms or difficulty in passing symptoms are necessarily related to obstruction. And not all storage symptoms are necessarily so-called irritative. And hence the use of terms like prostatism, obstructive symptoms, or irritative symptoms should not be actually, these terms should not be used anymore. And these should all be replaced by a non-specific term, lower urinary tract symptoms, because that does not confer some sort of an etiological diagnosis by when you give that phrase. It's exceedingly common to have lower tract symptoms. Almost 3/4 of the general population reports some or the other symptoms at some point of time. And if you look at various specific types of symptoms like voiding difficulty, urgency, and so on, you will find that these are all quite common, depending on how you define them across society. And as we just mentioned, with the metabolic syndrome, also the lower tract symptoms increase with age. I've shared a long relationship, in fact, with Professor Paul Abrams over the years. And he's almost a mentor to me, and we speak with each other almost every maybe 2 or 3 months on a FaceTime call. He's an Indophile, loves his mango lassi, and loves the Indian summer, surprisingly for a Britisher. But he really contributed a lot to this field and has revolutionized our thought process in terms of lower tract symptom management. Now, if this were to be the population of all the men who are above the age of 50 years, then about 50% of these men will be having histological benign prostatic hyperlipidemia, BPH. About 50% of the men who have BPH will show an anatomical enlargement of the prostate gland or benign prostatic enlargement. About 40% of all these men will have lower tract symptoms. And you can see here that these circles are not overlapping with each other. And finally, there'll be a subset of men who have bladder outlet obstruction. Now, if I take away the circle for the benign prostate, the BPH, histological BPH, because histological BPH is really we are not really bothered about the histology, right? So lower tract symptoms, benign prostatic enlargement, obstruction. And what this tells us is that there's a group of men in whom the symptoms of the lower tract are completely unrelated to the prostate. Then there's a group of men in whom the symptoms are due to obstruction, but they don't have any prostatic enlargement. You have men who have an enlarged prostate who are neither obstructed nor have symptoms. You have men with an enlarged prostate with symptoms, but unrelated to the obstruction. And finally, you have a small group of men who have classical obstruction, prostate enlargement with symptoms attributable to the obstruction. This is important to understand conceptually, because if you don't understand this, then the logic of managing lower tract symptoms will continue to elude you. And then a common condition, not directly or independent of obstruction, is a storage disorder, what we call the overactive bladder. And the overactive bladder is essentially a symptom complex, primarily driven by urgency in the absence of any other abnormality like an infection or other pathology. An overactive bladder is very common, characterized by frequency, urgency, incontinence, nocturia. There is some relationship clearly with obstruction and overactive bladder symptoms, but these are independent conditions in their own right. So what's the association between metabolic syndrome and lower tract symptoms? You have higher odds of finding lower tract symptoms in men with metabolic syndrome and vice versa. That means men with lower tract symptoms, higher incidence of finding metabolic syndrome in men with lower tracts and so on. The risk of lower tract symptoms increases with increasing severity of the metabolic syndrome. So the more severe the metabolic syndrome, the more the likelihood of finding LUTs. And even metabolically healthy obese individuals. So you can have people who are obese, but they have no other metabolic disorders. Even they are at higher risk of developing lower tract symptoms compared with non-obese individuals. About 1/4 of elderly men with hypertension have LUTs. And if you look at the obese men who were part of the PLCO cancer study, this was a very famous international cancer screening study, often quoted. The obese men in this showed there was a 25% higher incidence of nocturia and a 10% higher incidence of finding prostatomegaly more than 30 grams. There is a clear association between diabetes, which is so common in our country, and lower tract symptoms. So they're very common, and depending on whether it's type 1 or type 2 diabetes, it's at least a quarter of the patients, reaching up to 2/3 or even 3/4 of patients in some situations. They can have a broad range of lower tract symptoms, including frequency, urgency to start with, but later typically tend to have difficulty in passing urine. And a sort of an end-stage diabetes-related bladder problem is what we call a diabetic cystopathy, which is characterized by a triad of problems, which is reduced sensation from the bladder. There's a damage to the afferent nerve system. There's an increasing capacity of the bladder. So these bladders will typically have capacity of 800, 900, 1,000 ml and so on. And there's an impaired contractility, which results from this chronic overdistension, presumably, and also from the chronic hyperglycemia, causing large residuals, difficulty in voiding, and ultimately refractory retention. And there's an association between the duration of diabetes, the quality of the control, whether it's a type 1 diabetes and peripheral neuropathy with these conditions of diabetic cystopathy. This is a bladder pressure trace called a urodynamics, and there's only one trace that I'm going to show you today. And the third line from the top is the line that you should look at, which is the detrusor pressure, which is conventionally the way we label the bladder pressure. And you can see here that we have filled about 900 ml into this bladder. That's the bottom line you can see where the amount of bladder fill is mentioned. After filling 900 ml, the bladder pressure remains close to zero. So this is a bladder which is very compliant. It's like a soft balloon. You go on filling it, it goes on filling without any rise in pressure. 900 ml is clearly much more than an average person would tolerate in their bladder. And you can see here, there's almost no sensation. We stopped filling because we had filled so much rather than the patient telling us that we need to stop. There's a very large capacity. It's a highly compliant bladder, good elasticity, you can say. There's acontractility when the patient tries to pass. There's no discernible detrusor contraction after being told to pass urine. And there's a large residual urine because the patient didn't void it at all. And so these are the classical features of what we call diabetic cystopathy, which results from an end-stage diabetes-related bladder damage. Let's look at some of our own data. And in our own data published in 2020 of 1,596 men, and these were men who had refractory lower tract symptoms presenting for a urodynamics. 31% of these patients had diabetes and about 36% had hypertension. And if you look at the prevalence of diabetes in the population, then you can see that with age, with every decade of age, the prevalence of diabetes kept going up. So in the group of men who were between 18 and 30 years, it was very small, about 1.6% or so, but it went up to 64% in the age group above the age of 80 years. So a progressive rise in diabetes, and you can see very clearly here that in the so-called lower tract symptom elderly male population, at least half the patients who reach us are actually diabetic. So in the Indian, especially patients who are having refractory symptoms, because this is data collected from patients who presented for urodynamics for refractory data. This is not OPD data, be careful in interpreting it. So these are the patients who had the worst problems not getting managed by medication. Diabetes is very prevalent in this population. So what might be the mechanisms of interaction between these conditions? If you look at obesity and lower tract symptoms, we know that obesity impacts urethral sphincter. There's fat deposition around the sphincter. There is periprostatic fat thickness, which increases in these patients, and this seems to correlate with poorer IPSS and prostate volume. Obesity is associated with peripheral nerve damage. You get neuropathy in about 11% of normoglycemic obese, 29% of pre-diabetic obese, and about 1/3 of men who are diabetic and obese. So you can see that as we add the risk, then the possibility of peripheral nerve dysfunction keeps on increasing. And you have a range of inflammatory molecules that are released as a consequence of obesity. Now, I recognize that these mechanisms that I'm telling you are not all encompassing, and there are a whole lot of other potential mechanisms, and those mechanisms also range in the other slides that I'm going to show you, through which there's an interaction between these conditions. And not all of these are really understood to the best of our abilities at this point. If you look at the interaction between hypertension and lower tract symptoms, there's a link between salt intake, hypertension, and nocturia, which is a common bothersome urinary tract symptom. There's link between hypertension and nocturnal polyuria, the volume of urine produced, large volumes of urine produced in the night. There's a link between the sympathetic autonomic nervous system and bladder outlet resistance. We know that there's a lot of alpha adrenergic receptors in the proximal urethra and the bladder neck area, especially in men. And there is some conjecture that higher autonomic system, let's say tonicity, might give rise to bladder outlet obstruction or primary bladder neck obstruction in young men. There's research on this going on, but it's not an established link at this point. There's also a link via erectile dysfunction. So we know that there's an association between hypertension and ED, and there's an association between ED and lower tract symptoms. And again, a variety of mechanisms, including pelvic vascularity and so on. So there are a whole lot of mechanisms by which the interaction between these different conditions occur. And then when you look at diabetes and lower tract symptoms, there's the effect of chronic hyperglycemia, oxidative stress, and the impact on the neuromuscular mechanism of the lower urinary tract. There's a consequential damage due to sensory impairment. So we know that initially the bladder loses sensation. And when there is a loss of sensation, then the bladder tends to get over full, because the sensation of bladder fullness is less to the patient, so the patient doesn't realize that the bladder is full. And when there's chronic over distension, then the bladder power also starts getting reduced. So we know that there are consequences that happen from the initial insult to the bladder. And there seems to be a two-step process: an initial muscle hypertrophy, which may be accompanied initially by overactive bladder-like symptoms. But later there's a loss of muscle power, as I said, and decompensation, termed diabetic cystopathy. There's also the added consequence of polyuria in patients with uncontrolled diabetes. And this is especially prominent in patients who have IDDM, where sometimes it's really difficult for them to get a tight control over their diabetes. And many times they reach us with bilateral upper tract dilatation, which is related as much to the lower tract problem as it is to the large urine volumes that they are producing. And it's important to identify that and tackle that, because if you don't tackle that, the upper tract morphological changes are not going to settle down. And then finally, there's the impact of neuropathy on the pelvic floor itself. So what about the treatment of metabolic syndrome, and how does that impact lower tract symptoms? So what's the impact of bariatric surgery? And that's our best model, so to say, for the treatment of metabolic syndrome. So clearly, not everybody with metabolic syndrome requires bariatric surgery, but it's our best model in which we can study what happens to the lower tract, lower urinary tract, when you tackle various components of the metabolic syndrome, because you have a one-step major sudden correction of the metabolic abnormality. So if you look at the impact of bariatric surgery on nocturia, then 522 patients across 5 studies in a systematic review, there's a drop of about 2/3 of a nocturia episode following surgery per night, which is a substantial difference for a lot of patients, because that means every second, third night they will get up one time lesser. If you see the impact of bariatric surgery on male lower tract symptoms in general, again, another systematic review recently, 334 patients, 7 studies, there's a mean improvement of 2.8 points on the IPSS symptom score. So the IPSS symptom score, just very briefly, because I know you're not urologists, is the commonest or the most commonly used symptom scoring system for patients with lower urinary tracts, men with lower urinary tract symptoms. It's not perfect. It has its own drawbacks, but it's most commonly used. So there is a significant 2.8 drop in the IPSS score following surgery. And the score can range up to 35. What's the impact of bariatric surgery on overactive bladder symptoms? If you look at this, this is a larger number of patients studied, but a word of caution here, most of the patients in this group were actually women. There's a 59% relative reduction in OAB medication use, and the benefit was greater in women as compared to men. So again, bariatric surgery improves each of the different components of lower tract symptoms. And then finally, what's the impact of bariatric surgery on urinary incontinence? And this is an observational cohort study, 422 men. This is the male component of this publication. So there were a total of 1,900 patients. About 3/4 of the patients were women. The men had a median BMI of 47. So these were really huge, the obese men, and an average age of 50. About 1/5 of them had incontinence at baseline. And the 1-year prevalence came down to about 10%. And at 3 years, it was about 12%. A little higher than that at 1%, but still much lower than what was seen at baseline. And this possibly mirrors these changes, some of the changes which were happening in their body morphology, as some of them tended to, again, gain weight and so on. So what's the importance of recognizing lower tract symptoms or LUTs in patients who have metabolic syndrome? We know that metabolic syndrome is common in medical practice. I guess many of the patients that you see in your practice today are suffering from metabolic syndrome. And we know that lower tract symptoms are common in patients who have metabolic syndrome, even if the patient may not come out with it. So they may come to you for obesity, they may come to you for hypertension or diabetes control. But we know that lower tract symptoms will be common in this group, even if they don't voice it when they meet you. We know that the quality of life in these patients is associated with lower tract symptoms. So in a diabetic patient, the blood glucose level might not bother the patient, but the lower tract symptoms that accompany might bother the patient. And so quality of life is associated with lower tract symptom in these patients. And so if you recognize and treat lower tract symptoms in your patients with metabolic syndrome, it's likely to improve patient satisfaction. And a satisfied patient is good for your practice, right? So let's look at 2 illustrative cases to try and understand some of the concepts with regard to the treatment of lower tract symptoms in general, as well as some references to the metabolic syndrome patient. So let's take a look at a 62-year-old male with voiding LUTs, nocturia 3 per night, no infection, long-standing symptoms. He's diabetic, hypertensive, and morbidly obese. He's taking tamsulosin 0.4 milligrams at bedtime. He's moderately bothered with his symptoms. He has a normal focused neurourological exam, which is a component of the urological assessment. He has a normal foreskin, very important to check in the diabetic patient because many of them develop phimosis and they're embarrassed to tell anybody. The ultrasound scan shows a prostate 60 grams in size, a residual of 80 by 250 ml. Very important to look at the void percentage. Don't go just by the post-void residual. What we are interested in is what's the voiding efficiency of the patient. And so this patient has a voiding efficiency of about 2/3, 60, 65, 70% voided and about 25, 30% remaining behind. And a flow rate of 9 ml per second. The normal flow rate is between 15 and 25, or at least upwards of 15. Most patients under a flow of 10 tend to get bothered. So what's the next best step? Is it a change in the alpha blocker? Is it addition of a 5-alpha reductase inhibitor like dutasteride or finasteride? Should we substitute a PDE5 inhibitor? Should we add an overactive drug? Or should we offer urodynamic invasive evaluation? Or just get a bladder diary to understand his problem? Well, it so happens that for a large proportion of men, voiding symptoms are not really all that bothersome. So let's say if my urine flow or force is about 80% or 70% of what it should be, instead of taking 60 seconds in the toilet, I might take 80 seconds in the toilet. That's not really all that bothersome. For most men, unless the flow drops drastically, it's the other components of their lower tract symptoms which really bother them. And in this patient, what stands out is that this patient has nocturia, and it so happens that's a bothersome symptom for him. And really, to understand nocturia, you just can't do it without a bladder diary. So this patient, before anything else, actually requires a bladder diary first. So if you look at nocturia, and nocturia means the requirement to get up in the night to pass urine, Nocturia can be broadly categorized into two different groups. One, where the volume of urine in the night is large, nocturnal polyuria, and the other, where the volume of urine in the night is not large and yet the patient is going more often. And these are two totally different groups of patients. Very important to define this because your direction of management is totally different for these two groups. As I said, you can't really do this without a bladder diary. In the elderly individual, if the nighttime urine volume is more than 1/3 of the 24-hour volume, we call it nocturnal polyuria. So let's say if my urine volume is 1800 ml in 24 hours and I pass 700 ml at night during my the time when I go to bed with the intention of sleeping till the time when I wake up. I'm trying to make this as non-technical as possible. Then I have passed more than 33%, and this is clearly nocturnal polyuria. This is age dependent, these cutoffs, but in the elderly individual, this is most often what we are looking at. It's about 1/3. So the bladder diary, as I said, is critical to making a diagnosis. And let's look at two different situations. Situation one, where the nighttime urine volume is 300 ml between those 3 episodes. So let's say an average of 100 each time. And then to the nighttime urine volume, you need to add the first morning urine because the first morning urine was also produced at night. So the first morning urine being 200 ml. So this patient's nighttime urine volume is 500. And let's say if the 24-hour volume was 1800, this patient is not having nocturnal polyuria. And in the given clinical setting, the nighttime problem might get managed as overactive bladder, but you might also improve the patient's ability to hold in the night by improving their voiding efficiency by taking care of obstruction. In a second situation, you could have a nighttime urine volume of 500 and a morning volume of 300. And let's say this patient passes 800 out of total 1800 in 24 hours. That's 44% of the total volume of urine in the day passed at night. This patient has nocturnal polyuria. This patient, we need to manage identify why and manage the nocturnal polyuria. And nocturnal polyuria has a key link with metabolic syndrome. So we know that pedal edema is more common in the patient with metabolic syndrome, and patients with pedal edema are invariably going to produce nocturnal polyuria because the moment they go to sleep, they raise their legs at night. It's like getting an infusion of 3 or 4 liters of fluid in the middle of the night because the fluid from third spaces, sequestered third spaces, is remobilized through the blood and comes out as urine. So anything that tackles pedal edema will improve their metabolic with the lower tract symptoms, the nocturia. So foot elevation, salt restriction, compression stockings, and if required, use of an afternoon loop diuretic can all help in managing nocturia related to pedal edema. And of course, taking care of the underlying condition if there is one. So let's say patient has impaired cardiac function, liver dysfunction, and so on, taking care of those things. Obstructive sleep apnea, again, more common in the metabolic syndrome patient. And we know that OSA has a link with nocturnal polyuria through a complicated mechanism that you are all very familiar with related to the atrial natriuretic peptide. So again, identifying and treating very important. Nocturnal fluid intake or consumption of diuresis inducing food or beverages. Let's say somebody takes lots of fruits, water-containing fruits late at night, or drinks a nightcap alcohol before sleeping, or takes coffee. These are all diuretics and will cause nocturnal polyuria. It could also be part of a global polyuria because there are more than one definitions of nocturnal polyuria. Not all of them rely on the proportion percentage that I just told you about. There could also be associated lower tract symptoms. And in those situations, you try and treat the associated lower tract symptoms. So if there's urgency, you treat the overactive bladder. If there's obstruction, you treat avoiding difficulty, you give an alpha blocker. If everything doesn't work and you're left with a situation where you have unexplained nocturnal polyuria in isolation without global polyuria, then as a last resort, you might require to use desmopressin with serum sodium monitoring. Now, let's say this patient is bothered not by the nocturnal polyuria or nocturia, but is bothered by the voiding difficulty. So the same patient, same history, bothered by voiding difficulty, is already on the alpha blocker. So what's the next best step? So again, the same steps are here in front of you. Change the alpha blocker, add a 5-ARI, substitute a PDE5 inhibitor, add an OAB drug, or offer urodynamics. And this patient is on tamsulosin. Well, guidelines tell us that all the alpha blockers have an equivalent efficacy. So regardless of what you might read at different locations and different publications, we are clear about this, that alpha blockers are having an equivalent efficacy. There is no major difference in the efficacy between the various alpha blockers. They all have a similar improvement in the IPSS symptom score. They are differentiated primarily by their adverse events rather than by their efficacy. So changing the alpha blocker from tamsulosin to something else is not really going to help and is not a recommended thing at this point for this patient. What about adding a 5-alpha reductase inhibitor like dutasteride or finasteride? Now, the first thing here to remember is that having a baseline PSA is mandatory. So you must have a PSA because 5 ARIs will alter the PSA and it can impair your ability to make a diagnosis of cancer. So all these patients should have a PSA. All of them should have a digital rectal exam because high-grade anaplastic carcinomas may have a normal PSA despite having widespread metastasis. This patient has moderate bother. The patient should have prostate size more than 40 grams. If the prostate size is less than 40 grams, do not use dutasteride or finasteride because it doesn't work. It's like a placebo. Why moderate bother? If the patient has very severe bother, many of those patients in a setting of refractory to alpha blocker might actually be candidates for surgery. But if they have moderate bother and they're willing to wait for the effect of 5 ARIs, which takes several months to set in, then it's reasonable to start them on a 5 ARI. We know that the combination is more effective for improving IPSS symptom scores, the flow rate and the residual. There's a reduction in long-term progression and retention risk when you add a 5-alpha reductase inhibitor. And hence, for all these reasons, adding a 5-alpha reductase inhibitor is a reasonable option for a patient who has refractory voiding difficulty despite the alpha blocker. But then why not use a 5-alpha reductase inhibitor for all the patients, men with large prostates? Well, adverse events are increased doubled when you add a 5 ARI or dutasteride to an alpha blocker for every patient. Erectile dysfunction is more than doubled. Ejaculatory dysfunction is more than tripled. Retrograde ejaculation more than doubled, and a loss of libido more than tripled. For all these reasons and the fact that this is a commitment to 2 long-term medications instead of 1, not all men are suitable candidates for adding 5-alpha reductase inhibitors to their alpha blocker. How about if the same patient had come to us with a small prostate and was refractory? So men who have a small prostate and voiding difficulty tend to respond well to an alpha blocker, but sometimes they don't. So let's say this patient has not responded, and instead of the 60-gram prostate has a 25-gram prostate or a 20-gram prostate. What's the next step? And clearly, as we just discussed, change of the alpha blocker is off the table. Addition of the 5-alpha reductase inhibitor is also off the table because I just told you that anybody less than a gland size of 40 grams should not be offered a 5-alpha reductase inhibitor. So now we are left with some of these other options. And a PDE5 inhibitor is something that you should consider, especially in the patient with metabolic syndrome, because patients with metabolic syndrome are at a higher risk of erectile dysfunction. They won't tell you. So ask the patient, does he have erectile dysfunction? Why? Because we know that if you give tadalafil, which is a long-acting PDE5 inhibitor, in a dose of 5 milligram once daily, then in that use of tadalafil gives an IPSS reduction in symptoms of lower tract problems, similar to tamsulosin. But the interesting thing is you don't have an improvement in the flow rate. So you get a benefit which is equivalent to tamsulosin without an improvement in the flow rate. So there's also the option of combining with tamsulosin, although there's some literature to suggest that there could be a potentiation of hypotension. So you need to be a little careful, but you can give a combination of tamsulosin and tadalafil in patients with refractory symptoms, especially if they have erectile dysfunction. Now, the data suggests that you could use tadalafil even if the patient does not have erectile dysfunction. But clearly, if the patient does have erectile dysfunction, and many patients with metabolic syndrome will, then it's reasonable to start them on tadalafil in addition to or as a substitute for the alpha blocker. And of course, a word of caution, you need to check whether the patient is on nitrates. Let's take a quick look at a second case. This is I've kept the same history stem for this patient, except now that this patient's primary symptom is storage LUTs. So the patient is primarily bothered by frequency, urgency, and difficulty in control. All the same history. is on tamsulosin, moderately bothered. The bladder diary shows small frequent voids, multiple urgency episodes. There's no nocturnal polyuria. A urine exam shows pyuria, and a culture is positive for E. coli. Well, what's the next step? A course of antibiotic, adding the 5-ARI, substituting the PDE5 inhibitor, adding an OAB drug, or offering urodynamics. Right, now you can see here that adding a 5-ARI or giving PDE5 inhibitor is not really the way forward for a patient whose dominant problem is storage LUTs. So this patient has a reasonable void efficiency. If the patient had a poor voiding efficiency with a large residual, and a small void efficiency, then it's reasonable to try to improve their voiding efficiency by adding dutasteride. But this patient is not like that. So number 2 and number 3 are off the table. What about a course of antibiotic? Well, this patient has no clinical infection. There's no dysuria, there's no fever, there's no clinical feature to suggest that this patient is infected. And these symptoms are long-standing symptoms, as I've mentioned here. It's not a 4-day or 3-day history of symptom. There is no role for using an antibiotic in this setting. There's in fact data to show that if you use an antibiotic in a setting like this, then you increase the odds of a symptomatic infection in the patient by replacing harmless protective bacteria by harmful ones. So do not use an antibiotic in a setting like this unless you have a clinical infection, because it harms the patient in the long run, not just cause trouble related to antibiotic associated side effects or causing drug resistance in the microbial population, but it actually increases the odds of a pyelonephritis and febrile urinary tract infection when you use an antibiotic like this. So what about adding an OAB drug? And I'm going to take you back to an old paper. This is almost 18 years old. And I'm going to share with you my own take on this paper because I think it's very instructive to take a look at this paper, right? I must warn you that some of these generalizations in terms of proportions are all done by me. They're not from the authors. So in this study, the authors studied 144 men who had either bladder outlet obstruction alone, or they had bladder outlet obstruction with OAB symptoms. So the bladder outlet obstruction alone group, given an alpha blocker, about 3/4 of the men improved. And as I said, these proportions are a generalization that I have done. They're not from the authors. It's approximately 3/4 of men improved with an alpha blocker alone. About 1/4 of men who had bladder outlet obstruction alone did not improve with the alpha blocker alone. In this group, adding an anti-muscarinic improved 40% of the remaining patients. So you can see here in men who have obstruction alone, they have no symptoms related to overactive bladder or storage. In the men who don't respond, even here adding an OAB drug seemed to improve a substantial proportion of the men. So it's possible that many of the men don't realize that it's a storage symptom bothering them. They don't describe it, but it's actually there. And if you look at the men who had obstruction with OAB symptoms, with the alpha blocker, only 1/3 improved. 2/3 did not improve. And adding an anti-muscarinic improved 3/4 of this group. So clearly, if you have a patient with lower tract symptoms, with or without OAB symptoms, by combining or adding an OAB drug, you can take care of a lot of patients who have not responded to one of the drugs alone. And I presume that you could substitute here mirabegron for the anti-muscarinic to get a similar benefit, because I believe it's almost like a class action of using a storage-related medicine with a voiding-related medicine. So what do the guidelines recommend? The guidelines say use muscarinic receptor antagonists in men with moderate to severe LUTs who have mainly storage symptoms, and don't use the anti-muscarinics if the post-void residual is more than 150 ml. Now, the data is with the absolute post-void residual, but as I told you, the void percentage is important. So if the patient has a pre-void volume of 800 ml and a post-void residual of 150, I can tell you that you will be very safe in using an anti-muscarinic on a patient like that. You can use beta-3 agonists like mirabegron in patients with moderate to severe LUTs who have storage symptoms. And you can combine these drugs with the alpha blocker in patients who have both storage and voiding symptoms. So what's the approach to the patient who is refractory in terms of their storage problems? Very briefly, obtain a bladder diary if you've not done it already. Take a look at it. That might give you a clue as to what's happening. Look at patients' expectations, because sometimes you need to match the patient's expectations. And very elderly, a 75, 80-year-old man, it may not be possible to make him for him to be able to hold the way he used to hold at the age of 20, for instance. Change of a drug or a dose of a medicine, let's say if he's on solifenacin or if you want to add mirabegron and so on, recheck the residuals, especially if they were marginal, they might have grown up now, check his drug compliance and look for alternative diagnoses like subtle neurological problems. And in this population, especially look for features to suggest, for instance, NPH, normal pressure hydrocephalus. Look for Parkinsonism, multisystem atrophy, dementia. All these things are common in this group of patients. And these will all have an impact on lower tract symptoms. And sometimes these patients don't present with the neurological symptoms. They actually present with the urological symptoms. Especially for patients with MSA and NPH, their primary presentation can actually be to the urologist rather than to the neurologist. Again, all antimuscarinics are similar in efficacy. So changing from one antimuscarinic to another is unlikely to yield benefit. So if you're not getting a benefit with an antimuscarinic, add mirabegron. That's more effective than trying to increase the dose of solifenacin, for instance. And even a 5% increase in weight loss, 5% weight loss will help in terms of controlling the patient's symptoms. What's the impact of metabolic syndrome and the outcome of lower tract surgery? Very briefly, men who have metabolic syndrome show inferior improvements in voiding symptoms. They have lesser improvements in their symptom score, their flow rates are poorer, and they are also more likely to have persistent storage symptoms if they are having metabolic syndrome. Okay. A few words about tamsulosin, and this is something that my hosts wanted me to discuss. So just a brief bit about tamsulosin. So the typical dosing of tamsulosin is 0.4 milligrams at bedtime. You're all aware and you've been using this drug. It's a selective alpha-1 blocker. It has less severe side effects compared to non-selective alpha blockers. It's effective for avoiding LUTs regardless of the presence or absence of metabolic syndrome and the presence or absence of prostate enlargement. It's effective and safe in men with concomitant hypertension, diabetes, obesity, and other components of metabolic syndrome, and it doesn't interfere with those therapies. So your use of antihypertensives, for instance, is not altered by your use of tamsulosin, despite the fact that it's actually an adrenergic blocker. The oral controlled absorption system or OCAS formulation is better tolerated with less impact of food in the gut, and there's less propensity for developing postural hypotension when you use the OCAS formulation. It's important to remember that tamsulosin is associated with the floppy iris syndrome. This is again a class action of the alpha blockers, but tends to happen more often with tamsulosin. So it's important to remember this. If a patient is likely to undergo cataract surgery and he's not yet started an alpha blocker, it's reasonable to get the cataract surgery first and then start the medication. And the ophthalmologist must always be aware of the fact that the patient is taking an alpha blocker. So to conclude, metabolic syndrome and lower tract symptoms are both common and increase with age. There's an association between metabolic syndrome and lower tract symptoms. The presence of metabolic syndrome can cause or aggravate lower tract symptoms, and it offers an additional therapeutic avenue to patients who have lower tract symptoms. Metabolic syndrome can complicate lower tract management, and that's more, of course, for the urologist. And finally, the recognition and management of lower tract symptoms in men with metabolic syndrome can improve patient satisfaction and health, improve the feeling of your well-being of your patients in your practice. With that, I think I will end my talk. We have about, I think, 15-17 minutes for discussion. And I will stop my slide share at this point and hand it back to Dr. Shyamashri. And let me see, I think there are some, I just saw a chat message. Where has it disappeared?
Yes, sir.
Shyamashri, are you there? Okay, there's a question that you sent. Okay, I don't know who's asked the question. So does the presence of metabolic syndrome worsen the condition of LUTs? And the answer is yes. And it's through a variety of mechanisms that this happens. But there seems to be a clear link between metabolic syndrome and LUTs. And not just that, the more severe the metabolic syndrome, the more the impact on LUTs. So there's an association, not just in terms of presence or absence of lower tract symptoms, but also in terms of a degree of metabolic syndrome versus the degree of LUTs. In the cascade of treating a patient with LUTs and metabolic syndrome, when does pharmacotherapy come into play? Okay. So I'm assuming, because I'm the urologist and you're the physician, you're asking me pharmacotherapy for the LUTs, not for the METs, right? Now, as far as pharmacotherapy of the lower tract symptoms is concerned, we must remember that for an overwhelming majority of patients, lower tract symptoms are a quality of life problem, not a health hazard. So whether or not we give therapy to the patient is entirely the patient's choice, unless there are certain red flags that some patients might have, and most patients will not have a red flag, right? So if there are no red flags, then in that case, it's a patient's choice. And you always start with lifestyle changes. And in the lifestyle changes for the metabolic syndrome patient, a weight loss of 5% plus, a very modest goal, is an important component of management. When will pharmacotherapy be required? Any patient who is symptomatic enough in terms of avoiding difficulty or storage symptoms, and especially if with the storage symptoms, you've looked at the bladder diary, you made sure the patient is not passing 4 liters of urine in 24 hours and complaining of frequency. So if you've taken care of those things, you've done due diligence on your patient, then in that case, it's reasonable to start on pharmacotherapy. How important, the next question is, how important is taking the clinical history of the patient with LUTs and METs? Oh, very important. If there's one thing that you might have understood from all that I just discussed in terms of those 2 cases, it must have become apparent that the history is so crucial. On a daily basis, I see a lot of I have a lot of patients referred by colleagues, by patients who are frustrated because they've not been able to get their problem solved. And most of the times, solving their problems is on the basis of listening to them and trying to understand their problem. And the clue is always there. The clue is almost never in doing a test. The clue comes from taking a good clinical history and evaluation in terms of trying to understand. And there's some very common mistakes that happen. And one of the commonest mistakes that happens is use of antibiotics because the urine examination shows something. So the problem is, it's difficult to differentiate the symptoms of a UTI from the other LUT symptoms. And I can throw another googly into this by adding one more condition which we didn't discuss, which is bladder pain syndrome. So if you look at a constellation of patients who come into clinical practice, many of them have overactive bladder, which causes frequency, urgency. Many of them have bladder pain syndrome related problems, which causes discomfort or pain. And these 2 conditions concomitant with a urine exam abnormality, which is very common in the elderly population. If you look at diabetic elderly population, almost 70-80% patients you'll find pyuria in the urine. Carries no meaning. So the fact is, sometimes it becomes very difficult to differentiate, are these symptoms urinary tract infection or something else? So this is the commonest, if you were to ask me what's the most important referral problem for which patients frustrated land up with me, is that patients are getting treated for a urinary tract infection when it's actually something else. So very important clinical history. Next, what is the current standard of practice for patients with LUTs and obesity? Well, the Urological Society of India guideline on urinary incontinence, which I was the lead author for, recommends a 5% weight loss for patients with obesity to try and improve their urinary symptoms. Most guidelines suggest that urinary symptoms improve when patients lose weight. So I think it's a no-brainer that anybody coming with who's overweight and having lower tract symptoms needs to lose weight, not just for the lower tract symptoms, but for overall global health per se, and for improving their quality of life. So I think it's important for patients, when patients come with obesity to the physician, to get a history for lower tract symptoms. And if you ask for the symptoms, you'll very often find that the symptoms are actually there. And if they're there, then a bare minimum is to try and make sure that you're not missing a red flag. You shouldn't miss a cancer of the prostate. You shouldn't miss upper tract changes in a patient who has a lower tract problem. So you shouldn't miss a hydronephrosis, chronic kidney disease secondary to a bladder outlet obstruction, for instance. So those red flags should not get missed. And that can be, it's reasonable for most physicians to be able to achieve this much. And I think that should be done as a part of care. And you have a much more satisfied patient if you do that. The next question, are there any indicators of an advanced disease of lower tract symptoms? Right. As I said, for a vast majority of patients, when we are talking of disease severity, we are actually meaning how bothered is the patient. So we are talking in terms of patient-reported outcome measures, the IPSS score, or asking the patient, how much does this bother you? Because our severity is not based on how slow the flow is or how much is the residual urine or what's the size of the prostate. It's based on how much symptom does the patient have. So for a vast majority, that's the metric on which we decide severity. In some patients, we may feel that the flow has become so slow, or the residuals or the void percentages have gone so bad that they are now a health hazard, or they're developing upper tract changes. That's a different situation altogether. And when that is there, then the patient requires treatment, whether or not they are in denial of their symptom. That's a totally different issue altogether. So for a vast majority of people without the red flags, it's the severity or the advanced disease will be determined by the patient's own perception of their problem rather than by a report. But in a small group, it's based on the test that we do for the patient. Next question. Is there any background predisposition of the advanced disease of either LUTs with meds or individually? Background predisposition of the advanced disease. I am not exactly sure what the person who asked the question is trying to imply. So clearly, when we talk about metabolic syndrome, there are different components. So if you look at, let's say, the obese, metabolically healthy patient, who you could say is a predisposing kind of a situation where the patient is obese but metabolically healthy at this point. That kind of a patient also has a higher propensity for lower tract symptoms, as you can see from the Chinese long-term data study, population-based study. So they actually compared 6 different groups of patients. They compared patients who are metabolically healthy, metabolically unhealthy, lower tract symptom, they're not there. So 6 different groups. And they showed that the group of patients who were metabolically healthy, when they were followed up for a period of time, they were more likely to develop lower tract symptoms if they were obese compared to if they were not obese. So there is clearly a background predisposition. And some of these conditions are better understood by you than by me. For instance, insulin resistance and so on might be a predisposing condition for both of these things to happen. So a lot of this is still under a lot of research, for instance, and many of these things, the links are not very well understood at this point. But we do understand the phenotypic link. We may not understand the mechanisms very well right now, but we do understand, broadly speaking, what is happening. And I think that's what the clinicians in the clinicians domain right now, that's what is there. But clearly, once we understand the link better, we might be able to see how we can tackle these problems at an earlier stage in the clinical history, natural history of disease. Any specific milestone to notice before prescribing tamsulosin or other alpha blockers? Okay. So the first is, as I said, the patient should be symptomatic. So if the patient is not symptomatic enough to require treatment, just because a report shows something, it's not enough to start therapy. It would be good to have a baseline blood pressure measurement in your patient before you start medication. Good to warn patients that although uncommon, there's a small chance of getting a first dose phenomenon, a syncopal episode, a fall, because a fall and a fracture can become a terminal event in the patient. And patients who have, for instance, frailty, for instance, you want to be careful when you prescribe them. In some groups, it might make sense to start on lower dosages. So if I have, let's say, men, it's not uncommon these days to have men walking in at the age of 88 or 90. I might not start them on 0.4 milligrams of tamsulosin. I might start them on 0.2. Interestingly, in Japan, the standard dose for tamsulosin is 0.2. It's not 0.4. So it's reasonable to start vulnerable groups at a smaller dose. So extremes of age, sometimes we use alpha blockers in children. I use 0.2. Very elderly patients, geriatric patients, I sometimes use a 0.2 dose. And it's important to warn family members of the possibility of a first dose phenomenon. I think if you've done that, giving an alpha blocker is a reasonably safe thing to do. Even if there's concomitant medication, typically, you don't need to adjust the concomitant medication for hypertension and so on when you give an alpha blocker. So if you're using tamsulosin, which is a selective alpha blocker, you should be fine. If you use non-selective alpha blockers, which we don't commonly use these days for most of our patients, then obviously it's different, but otherwise it should be okay. Any other questions, Shyamshri?
No, sir. Sir, that is the amount of questions we have as of now. Yes, sir.
Do you have any question for me?
No, sir. So I have kind of put in the questions which I wanted to ask along with the other questions. So you have really answered everything, sir. So on behalf of CIPLA, we would really like to thank you for spending your valuable time and giving us the wisdom for the day and for the next decade, if I may say so. So thank you so much. And thank you so much for answering all the questions which we have received today. Thank you, sir.
My pleasure. Thanks and good day to everybody.